Good evening, Professor Lakhoo. Thank you for joining us today. Good evening, everyone. I am Monica Constantin, a fourth-year medical student at 𝐏𝐫𝐸𝐽𝑒𝑛 University of Medicine and Pharmacy in Bucharest, and together with Malviana, a fifth-year medical student, also at 𝐏𝐫𝐸𝐽𝑒𝑛 University of Medicine and Pharmacy, we will be the moderators of today's podcast for SURGICON. SURGICON is an international congress for students, entirely organized by students, in which Malviana and I are both involved as coordinators of the scientific department. With SURGICON, we aim to bring together young aspiring surgeons and provide them with the context in which they can engage with renowned international surgeons and role models. And speaking of role models, we are honored to welcome our guest on today's podcast, Professor Kokila Lakhoo, consultant pediatric surgeon at Children's Hospital in Oxford, past president of the Global Initiative in Children's Surgery, with a very high interest in global health, hence her constant involvement in the training of surgeons where they are locally needed. Through a collaboration that began more than 2 decades ago in Tanzania, she was asked to provide support in a newly inaugurated medical school by setting up a pediatric surgery service. Until then, she has continuously made trips to provide the local community with support. Nevertheless, we are eager to hear and learn more about her experience. Good evening, Professor Lakhoo. Thank you for joining us today.
Thank you very much for inviting me, and it's a great pleasure to be on this platform and sharing a platform with young people who are wanting to make a change and work together with all health workers around the world. So thank you.
Thank you. So firstly, could you start by sharing what inspired you to specialize in pediatric surgery?
So when I was a medical student, we had really very good obstetrics and gynae teaching. So, when you have very good teachers and you have people that are interested in students, you think, okay, that's what you really want to do. But when I shifted to starting my internship, I realized that it was actually the surgery that I really enjoyed. So I started my, as an intern, you rotate through different departments. And in the hospital where I worked, when you're on call, you cover all the specialties as well, besides basic general surgery. And somehow covering the wards in children's surgery, I just felt I landed on my feet. I just found it exciting. Always wanted to work with children. And because this was children and surgery, two other things that I really enjoy, I just felt this was home for me. And that's what made me want to do it. It just comes from inside. It's a passion to say, okay, this is where I belong. Because when you do your on call in children in general surgery, you cover ENT, you cover neurosurgery wards, you cover pediatric surgery wards, you cover thoracic wards, and it just felt that the pediatric surgery ward was my home, and that's how it all started.
Okay, thank you. Could you tell us how your work in Tanzania began and what your initial goals were?
Okay, so I was working in Oxford as a consultant pediatric surgeon, and we had a visit from the Vice Chancellor of a newly developed university at the foot of Mount Kilimanjaro in Tanzania. And he was a very visionary man. He felt that Tanzania has got a lot of generalists, and it's time that specialism stays in the country and not be sent to South Africa and India, where anything very specialized would go that way. Most of the general surgeons could manage children's surgery and were doing it well, but not in a specialist way. I had a full-time job. I had 2 children under 5, and it was a mammoth task, I thought, to try and develop a pediatric surgery. And with support from my husband, I went to do a visit and see whether this was feasible or not. And when I got there, it was very, understanding that there was a real need for pediatric surgery. And the general surgeons, adult general surgeons who did the work, were very interested and wanting to learn about children's surgery that they could do in a full-time capacity. I found a lot of the children's surgery patients were sitting in adult wards, and the pediatricians were desperate to have somebody do the children's operating. So there needed to be a collaboration between pediatricians and general surgeons to get this going. And during my time there, I realized that there was an empty ward which was used by mothers who were looking after their children in the pediatric ward. So there were 2 pediatric wards, and the 3rd ward was a place where mothers slept. So we pulled that together and told the pediatricians that if they could look after a 3rd ward, where all the children that get operated on get placed in that ward rather than in the adult ward, and see how we can take this forward. And that was the starting point. So the pediatricians were keen to look after the children, surgical children, and the adult surgeons whom I started working with, in the sense that they're trained surgeons, they know how to operate. And I started with the low-hanging fruit, like if you take a condition like Hirschsprung's disease, which is lack of ganglion cells, lack of cells in the lower part of the bowel. And the type of operation you do is very much similar to what the adults do for cancer, which they call anterior resection. So I started with that and just started showing a few differences and some of the major differences that you would do in children. And like that, we started. So I went yearly for 2 weeks on my own annual leave, probably about 10 days of my own annual leave and my own funding, and just work with my adult and pediatric colleagues on different conditions like cancers, like when you do nephrectomies for kidney cancers. They know how to do a nephrectomy, but just show them a few tricks of what needs to be done when you're operating on children and the differences and intraoperative care. So sometimes the pediatricians used to come in to help with the intraoperative fluid management. And as time went, we dealt with condition after condition after condition. And over time, we now have almost about 15 pure pediatric surgeons. They have their own training scheme. Dual one is with a Pan-African body called the COSEXA, where they do training of pediatric surgeons. And they have their own university-based MMed to train pediatric surgeons. And as time has gone, more and more of the junior people have become senior people. And now we have about 7 centers that have pediatric surgeons that are trained to do pediatric surgery. And there are 3 centers that are needing a bit more pediatric surgical care. So as time is going, as they qualify them, they put them into centers where we can build up pediatric surgery services for children. So that's the story.
Thank you. I feel like this is very inspiring, and the seed that you planted truly became not one flower, but a plentiful of flowers that are blooming right now. And it's truly inspiring to hear that. So my next question is, looking back, what do you consider your most significant contributions to the field of pediatric surgery and global health?
I think the most significant contribution to me is empowering local people. So empowering people that you work with. I work with a team in Bangladesh and I work with a team in South Africa, mainly developing research capacity. And in Tanzania, mainly developing clinical and research capacity. And when you start providing the tools for people to use and support them in a collaborative way, rather than, I have all the answers and they don't have the answers. That's not the way I worked. From the beginning, I called it sharing of skills. Yeah? Whether research skills or whether it's clinical skills. But we were on equal footing with my colleagues there, and we shared our skills to develop and bring about local empowerment, because local empowerment then is sustainable.
What projects have you initiated that aim to improve surgical care in low resource settings?
Okay, so projects, what I find is that, you don't come up with an idea and then say, okay, this is what we're going to do. So I'll just give you an example of one of the many projects, but I think this is an ideal one to talk about, where I was with my colleagues and we were sitting in the nurse's office and talking through what are the problems and what do they think we should do better. And then they were kind of saying like, look, patients come from very far and they come with a disease that is quite late. And then we started the ward round, and then we said, okay, let's ask the parents, what do they think about the service we give? And we asked the parents, like, how do you feel by being here and what can we do to help you and make things better? And three of the parents kind of simultaneously said that, we're quite worried about, when our children, after they come back from surgery, after 3 or 4 days or so, some of them start smelling. And basically they were talking about wound infection. And they say that things like yellow stuff starts coming out. And we said, do you think we can do something about it? And they said that's what worries them the most, because some children get very, very sick and some children die after they get very sick with this yellow stuff coming out. So we started talking. There was one of the auxiliaries, which is not a qualified nurse, but a support nurse, and said that she was working in one of the very small clinics. And what they used to do is that they used to bath the patients, whether adults or children. They used to tell them to take a bath, and the morning of the surgery, and tell them to just clean themselves. So we looked into that, and we realized that, okay, wound infection was a major problem, and we needed to do something simple. And with this auxiliary saying that they used to bathe the patients and they didn't see much infection. So we did a randomized control trial where we took a lot of patients that were going to theatre just the way they were. Like some consultants wanted a betadine bath, some wanted an antiseptic bath, some wanted preoperative antibiotics, some wanted no change. And we had an intervention arm where we taught the parents, we gave them soap just from the shops that didn't have any antiseptic properties and a towel, and told them to bathe their children the morning of the operation. So we did a teaching program. The nurses did a teaching program with the parents to say, this is how you do it. And if it's an abdominal operation, they clean the umbilicus well. If it's a neck operation, clean behind the ears and the nostrils well. If it's a groin operation, make sure that the groin creases are cleaned much better. And so we started the trial, and within 9 months, we could see that 80% of the infections so we had 80% success of no infection in these children. So we were asked to stop the trial because it all went through properly through, getting ethical permission from the hospital, training up staff, getting a little bit of funding. There wasn't a lot of funding. I mean, we started off with just £5,000 that we raised from little pockets. And we further showed when we stopped the trial, we just found that because parents were engaged in looking after their children and engaged in helping, it was a huge, huge success by reducing 80% of the infection. And they were all kind of very happy with this, that contribution made a huge difference. And, when you celebrate in Africa, there's a lot of singing and dancing, and it was very exciting. But that's impactful research because people took it upon themselves to do this.
Can you please share what the most difficult situations that you had to encounter during your work in Tanzania were, and how you managed to overcome these difficult situations?
Okay. So there are always barriers to what you have to do, and you work through them together with your colleagues. So it's shared responsibility. But one that comes to mind very clearly is that I was working with my colleagues in Tanzania, and in the third year of what I started doing, there was change of management and change of ministry. And in Tanzania, it's like that the Ministry of Health could decide where you work so that they distribute healthcare evenly. And they came to the hospital, and the management decided that the two people that I had worked with for 3 years were moved away to another hospital, another two different sites. So when I got there, the people that I trained were then not there. And there was a lot of sadness amongst the team that I was working with to say, this is what's happened. And I said, no, let's look at it positively, that the two people that have been trained as pediatric surgeons are now developing pediatric surgery in two different regions, and let's start with new people, And it was a difficult call where there was a lot of sadness and unhappiness, and people were giving up. And I said, no, let's just pull together, and we don't regard this as a failure or a hurdle. Let's look at it as just a little bit of, we just took a few steps back and we start again, And in that way, we encouraged, my positive attitude pulled everyone together, and we continued. So that was the challenge of trying to get people to say that, look, it's just a delay. It's not a failure.
Okay, but how did you manage to conduct your research given that funding was not always available?
Okay. You don't need a lot of funds to do research. A lot of the work that I did when I started in Tanzania or in South Africa or Bangladesh, we did it with no funds because everyone was interested. I think what they were interested is learning how to do research, developing research skills, making it happen. So everything was done by goodwill. Yeah. And I've always felt that when there's goodwill and commitment, the research works. And then you realize that after a while, you can't continue doing this. And then once you show some results, I was lucky that there was a family in the UK called the 𝘱𝐿𝐴 family that appreciated the work I was doing, and they started supporting the work. So we would get, £20,000 to then take up something on a larger scale, or get people trained officially through official channel, get people to join courses that are relevant for their development, and then to get researchers paid, because a lot of them were nurses doing it on their own time, and that would be more funding for their families. So I actually believe that a lot of good research and work doesn't always need money. It's not always money driven. It's the commitment. And if they are doctors, they are paid through the normal channels. But when it comes to nurses and, healthcare workers, and then for them, the funding is very, very important. Not saying that doctors also need funding, because they're not always paid in the way that they are regularly paid like we are. So from that, when people start recognizing that the work you're doing is impactful, the funding started coming in. And just recently, I now have a huge grant from the NIHR to do trauma prevention in Tanzania and Zimbabwe because of the track record that I have.
That's amazing, and we hope that everything goes according to your plans, and fingers crossed. Now, in your opinion, how can healthcare systems worldwide improve to provide better pediatric surgical care?
So, as we said, our dream, my dream, and all of us in the healthcare system dream that people will get the same healthcare no matter where they are. It's not a country lottery, or it's not a lottery where if you live in UK, you'll always get better care, and you live in Tanzania, it won't be the same. So trying to raise the bar to make sure that it's not the fabric. Like you could have a very fancy ward in Oxford, but you can have a basic ward in Tanzania. The important bit is that the healthcare that is delivered is the same. It doesn't have to be a 5-star room. It's what you can give. And if people are have the training to deliver the same healthcare and also the resource to be able to do so. And yes, it's a dream for all of us, and it might not happen in my lifetime, but you can start from basics. And I think the dream is to have equity, which is exactly what I've described, and to get people to see that. And if we would all work together, surgeons, anaesthetists, administrators, advocates, NGOs, government officials, we can do it. We can do it. And a classical example is in Tanzania, we doing a project where we're training up district teams of nurses and surgeons to be able to do some of the children's work in a safe manner, not complex stuff, but at least basic stuff, and also be able to look after children and then resuscitate them and transfer them to the surgical center in a very equitable way. And we got funding from a NGO to start the project, and having seen the success of it, the government is now funding it with a little bit of input again from NGOs, but also realizing that this is important for the country.
Okay, thank you. Throughout your career, how have you balanced the demands of such a challenging profession with personal life?
Okay, so in life you have your training as a surgeon. You have to do your training. If you want a family, then you have that aspect, and you want to do research, and that is another phase in what you want to do. And what I did is that I grew up in South Africa, where there were lots of hurdles from a gender and from a diversity and racial point of view, because racism was legislature. It wasn't just practice, by people. It was actually law. And what I did was very determined to make sure that what I do properly, and spend a lot of time in making sure that I'm trained properly. And in South Africa, you can't escape that, because there's lots to do and lots of very skilled people that will help you train. And at the same time, I realized that I also wanted a family, but the best way for me, what worked was I sort of got into the surgical training, and in my training, I had to do adult surgery before I do a fellowship in children's training. And then I met my husband about 5 years into being a doctor, but I was a surgical trainee when I met him. And we were together till, I finished my adult surgical training, and just for him to understand that, this is what it's going to be like to be married to a surgeon. So we got married just before I started my fellowship in pediatric surgery. And that was easy because he already understood what adult surgical training is like. Pediatric surgery is a bit more intense, but easier. And I decided not to start a family till I've completed all my training. So I did that. And once I became a consultant, I felt I had more control over my time rather than having a time with a boss telling me what to do. So I then started my family and continued full-time work, but made sure that my children were in the nursery or in the childcare that the hospital provides. So I'm close to them. And in that way, and then once they started school, I lived very close to the hospital, so I could walk to the hospital, and chose a school very close so that I could drop them off, and my husband will then pick them up. So the way we worked is we worked as a team and not as a man's duty and a woman's duty, in the sense that I did the morning bits and dropped them off because I could control my time in the morning. But pick up, he did. And also he chose to do a job where he starts at 7 and finishes at 3. So he could pick the children up from school and come home and start the routine with the children till I got home. So it's important that to balance that, you need to work together, you need to work as a family. And we also kind of taught our children to help in the household duties, so that when we're there, they help with washing the dishes, so that we could spend time together and have fun time if everybody partakes in household chores. And in that way, we kind of grew as a family. And as they got older, they were a bit more independent. And while I was doing my general surgery training, I knew that the only way I would survive in a legislative country that had a barrier against me is to get involved in research. So as an adult surgical trainee, I did my research at nights and weekends on laboratory work. And at the end, when I finished my surgical training, very close by, I got my PhD as well. So I had an academic slant to my career, and I would always find something clinical to publish, which I thought, oh, okay, this is interesting, speak to the consultant and put the effort in. So by the time I finished as trainee and a consultant, I had about 50 publications, first author, and I had my PhD, which is a scientific research degree. And then I kind of made sure that I concentrate more on, so I didn't do many publications once the children came on, till they were about 7, 6, and 4 and 6 years old. And then I started picking up, attending conferences and doing more kind of clinical research, and then a bit of more global kind of research with people that my trainees, my SHOs, my house officers, keep stimulating them, and that's how I managed to balance my time and have a balanced life with a good family, and enjoy my work, enjoy my family, and enjoy the research work that I do.
Thank you for sharing your experience, and I truly believe that it can be inspiring for everyone. And I want to take notes right now because you're truly, truly inspiring. And lastly, what advice would you give to medical students who are interested in working in global health or pediatric surgery, and why not even both?
I think what you should do is follow your passion. Yeah, when you're working, there's something that you really enjoy, like say if you like pediatrics, or say you like orthopedics, and put your heart and mind to it, and then see how you can share that skill, because that is global surgery, where we want everyone to have the same facility and the same treatment, as I mentioned earlier. And I think believe in yourself, and as you go, it's not an easy route, because even in 2024, you will be told that, oh, you're a woman, it will be harder for you. And yes, it is harder for us, because we do want, a family. The world is changing, where responsibility for the children doesn't only lie with the mother. The fathers are also getting involved. There is a paradigm changing. It's not completely there, but it's going in the right direction. So I think it's important to put your mind to it, be determined with what you do, follow your heart, because if you really like something, you don't have to work hard at it, because it is something that comes from inside. And there are always kind of barriers, and you fall, there are difficulties. And I always say that, if you don't pass an exam, it's not a failure. If you don't get something in your training, like you can't, you needed to do that hernia operation, and the first few times you just didn't get it right, and your consultant is saying, no, it's not right, you have to do it. It's not a failure, it's just a delay, it's just a setback. So if you have this thing in your head that there are no failures in life, it's just delay, and you might move 3 steps back, but when you get back onto your feet, you'll move 10 steps ahead, and you will get there. And you need to tell yourself that, take your training into your own hands. When you say, okay, I'm struggling with stitching, So take like what I did when laparoscopic surgery, basically, as an example, came to me when I was already a trained surgeon. So I used to peel oranges, and I had a little box that I kept at home, which was made by a colleague, a registrar of mine, made me a training box where he just took a storage box and putting a camera and attached it to my small television. And I used to practice peeling grapes and peeling bananas and stitching oranges and that, just to keep my skills up. And when I learned to stitch, I was told by my consultant that you peel an oranges in one and then you stitch it to put it back into a ball. And it's a really good training ground. So you take things home, you keep trying, you keep practicing on your own, on your time when your children are asleep. So, but take it into your own hands to say, okay, I'm not very good at maybe this particular operation. So make sure that you get to that operation when it's done so that you learn it properly. And it's something that I learned from a very, a world leader. Mr. Mandela always said that don't judge me by the number of successes I had. Judge me by the number of times I've fallen down and stood up again. And I think just keep that in mind in your life, because it's important to show that it's not the people that just get everything on the plate. It's the people that struggle but don't give up. That's when you'll make it.
Professor Lakhoo, it has been an absolute honor to have you with us today. Your insights into pediatric surgery and your tireless dedication to global health have been truly inspiring. We are immensely grateful for the work you do and for sharing your knowledge and experiences with our audience. To our listeners, thank you for joining us for this special episode. We hope you found it as enlightening and motivating as we did. Your support and interest in these important topics are what makes projects like this possible. Until next time, stay curious and keep making a difference. Have a nice day.